Hi guys, this background MRI is of a patient who had a major right MCA stroke. So today in this snippet we'll learn what is your emergent intervention when you encounter a patient with a stroke and what are the guidelines guiding us. So for this patient, initial intervention or management would be managing his ABC, that is airway, breathing and circulation. Sure that you prevent the secondary brain injury. So how do you prevent the secondary brain injury? There will be certain heads which you have to manage, like management of hypoxia. So prevent hypoxia, prevent hypercapnia, because cerebral vasodilation secondary to increased PCO2 raises your ICP. Prevent hypocapnia because again the vasoconstriction will cause cerebral ischemia. Then maintain normothermia, very important. Maintain a high target sodium, almost up to 150 to 155. So we have certain guidelines we know regarding thrombolysis and thrombectomy. So our ECAS 1 and ECAS 3 guidelines do guide us about thrombolysis within 4.5 hours with alteplase, that is a dosage of 0.9 milligram per kg body weight with 10% given as a bolus over the first 10 minutes, followed by the infusion. Nectarplase at a dosage of 0.25 milligram per kg body weight. If the patient presents to you past 4.5 hours, then you do MRI diffusion weight imaging and perfusion scans. And based on your MRI perfusion scans, we can thrombolysis as guided by our ECAS 4 trials. Regarding the usage of... Yesterday, one of my residents called me in the night complaining that a patient has a hematuria secondary to the anticoagulants. And then he said, "Madam, don't worry, I have given tranexamic acid." Tells me, "Madam, there is nil urine output this hour." And boom. Waiting, there is a sudden fall in the urine output. Anyway, it was as simple. We did a small troubleshooting. We gave a bladder wash and released a huge clot. So this was mostly secondary to your tranexamic acid, which is a fibrinolytic agent which has high thrombogenic potential, forming blood clots and causing a sudden renal shutdown. Basically, tranexamic acid is a plasminogen activator inhibitor the clot to break down. That is, it causes fibrinolysis. So what do you think are the indications of tranexamic acid in critical care? We have CRASH 2 and CRASH 3 trials which have clearly proven that tranexamic acid, if given within the first 3 hours of the trauma, that is in the dose of 1 gram IV OD followed by 1 gram IV 8 hourly, has shown to have some amount of mortality benefit. The CRASH 2 trial was significantly done for polytrauma patients, but the CRASH 3 trial was extrapolated mostly to the traumatic brain injury patient. Then what is CRASH 1 trial? Is it something related to tranexamic acid? No, this is where you guys get confused. CRASH 1 trial is for the high dose of methylprednisolone which was given in traumatic brain injury, and this